Good morning, everyone. Thank you for coming this early. We have like a slight adjustment in the schedule. Unfortunately, the first session, all the three speakers have apologized for personal or emergency reasons. So, as usual, we are always ready to fill and help. So, we have made up like a new session, which is more focused for imaging. We're going to tackle three elements. We're going to talk about aortic valve, mitral valve, and the pulmonary valve. We're going to start today, and this is an interactive session. I know you're like, a little amount of people are here, but we're going to talk about the aortic valve first of all. Can we have the slides, please?
Yeah, Adams.
So we know that the aortic valve is like a complex, and it's the new thing that everyone is fascinated with it. We had lots of live cases yesterday transmitted, and we've seen the challenges that it can come up at any moment. So let's have a new thing about it. The bicuspid aortic valve, we haven't touched like much of it this year, but we know it to have a different morphology type, larger dimension. We know that it has very high calcium burden, and the RAFI always poses challenges. We have PVL, we have PPM, and the fear and always of annular rupture, the possibility of future of having a second TAVR. The classification that we most common is being used, the severe classification, and I would like to hear from our panelists. Dr. Ahmed, any thoughts about the classification?
Yeah, so this is a very nice classification, but just to simplify it, I would just say more practically, the patient was born with 3 commissures, or he was born with 2 commissures. So this is important because sometimes structurally looks like there is 3 commissures, but one commissure was fused. But there is another patient where the commissure is RFA, so there is no aerial commissure. And the third one, which is no commissure. So in this way, we have like three types rather than like make it more complex from the imaging point of view. So 3 commissures with the like later fused commissure, one of the commissures, or there are 2 commissures or with RFA, or there is 2 commissure without RFA. So that way more practical.
What about the sizing? It's always like a discussion. Should we go an annular sizing or supraannular sizing?
Yeah, so this is back and forth. Many people believe that annular sizing suffices, like very like adequate. Many other people who are doing a lot of bicuspid, they know the complexity of the root, the shape of the sinuses. So they go more like more detailed measurement for the annulus and 3 millimeter, 8 millimeter, 10 millimeter above the annulus to see the shape of the leaflets, how they open during systole. Because sometimes they open like either it's tubular or they fan or they make it like a taper. So from imaging point of view, if I see that the intercommissural distance is like very close to the diameter of the sinus, it is reassuring. The only thing that if the intercommissural distance is very small, this means that the valve will behave like a cone like this.
Yeah, we're going to show Dr. Ahmed the picture of that. Yeah. Dr. Arifi, I would like to have your thoughts about the sizing point. If you're going to either go into a surgical valve or a TAVR valve, it's always a concern, the oversizing, and which holds the risk of annular rupture, or undersizing and the migration or the embolizing of the valve or PVL. What's your take on that?
I think from giving the advantage of having done TAVIs and surgery, what I can see in the bicuspid is not homogeneous. And I think when I see a congenital bicuspid, there is no interleaflet triangles. There is only 2 interleaflet triangles. And that's a true bicuspid. And we have to differentiate it between the functional or the pathological bicuspid. Pathological bicuspid always have 3 interleaflet triangles. And you don't see a raphe in pathological. And that's where the problem of the sizing because the geometry of the aortic root in bicuspid valve, very asymmetrical. When I even open for surgical, we do have to take time to size the valve because very asymmetrical aortic root, sometimes we have to make it circular in order for us to have an adequate size valve implanted in place. And that's where the difficulty with the TAVI is the asymmetry, and that's absence of interleaflet triangles make it more potential for BVL.
Okay, so
Dr. Sondos, if you allow me, before you go to the case, I think from CT point of view, there's a very important point also in the calcification and the leaflet length, because it is asymmetric leaflet. So the leaflet which is like facing the left main can be really long, that can be pushed against the left main or the right side. And the calcification also, if the calcification is more eccentric around the left main or around RCA, it can be pushed also to the ostium of the left main or the right RCA.
So let's make it like more interactive or more practical. So this is a 73 years old gentleman, history of heart failure, known case of diabetes, ejection fraction of 45, and we found that he has a severe bicuspid aortic stenosis with a PA pressure of 30. So we have some imagers with us, Dr. Anas, Dr. Jamila, Dr. Zakaria. So I would like to start with Dr. Anas. What are your thoughts about challenging posed in bicuspid to have the severity of aortic stenosis?
Yeah, so one of the things that we often find in patients with a bicuspid aortic valve is a larger LVOT, and this results in the overestimation or a higher calculated aortic valve area. So oftentimes you have some discordance, that you have a valve area that's 1 or above 1, when you have a Doppler mean gradient that's around 40. So I often find myself relying more on the Doppler assessment. So if I have a high gradient, even if I have a a valve area that's around more than 1, so using the Doppler, using the dimensionless index, obviously making sure that there's no hyperdynamic circulation. If it fits with the morphology of the valve, I rely more on that to grade the severity of the aortic stenosis if the valve area was overcalled because of a large LVOT.
Okay, so we move to the CT for the case. What are your thoughts, Dr. Ahmed, since you are our CT imager?
So this is what I mentioned, like if you see the calcification is really eccentric and it is like facing more the right coronary artery. So if you if you put a valve there, there is a risk of having what is in the around 10, 11 o'clock there, the calcification, you can push it to the right coronary artery. So the first thing when you see this image is to decide which type of the bicuspid. And then again, we go from up, down to see the commissures. I know there is but I can see 2 commissures, one at around between 12 and 1, and the other one between 6 and 7, and there is a raphe around 9. So that's a calcified raphe there. So yeah, this is the bicuspid, and this is a fuse between the right and non-coronary cusp. So this is bicuspid. We have to go down a little bit just to see if this is functionally bicuspid or not. So this is what I try to explain initially, that the relationship between the size of the annulus and the size of the intercommissural, like at the level of the valve, can be tubular, can be fan, or can be taper. I think what is the more dangerous is the taper, because usually what you do is you insert the valve at the level of the annulus to anchor at the annulus there and seal it. And then at the level of the intercommissural, the valve cannot open there. And you have to push it hard and sometimes cause complication to push it. For the others, maybe the risk is lower. So this is the...
So another way, like we have the circular method for supraannular. I mean, show of hand, who like to adapt the circular method in order for you to pick your sizing? I mean... What do you think, Dr. Ahmed? Do you use it usually?
So this is like as if you are putting like a virtual valve, and you know, if the ring, you put it at the left, and we do this. So you put like a circle at the level of the annulus, then you propagate that circle into the proximal aortic root until you reach to the level of the narrowest point in the opening of the leaflets. And by this, you would say how much expansion you can make during, you know, implantation of the valve.
Okay, great. So going back to our patient, our area is 515. We have good sinuses, sinus of Valsalva site were fine, and also the coronary heights were fine. And the area is, as we mentioned, 515. So the case went for a heart team discussion, and because of the consensus was the patient can go for either because he's in the lower aortic side, but the patient refused surgery and went for an TAVR. So this is, as Dr. Ahmed has mentioned, the circular method where you put the presumptive valve or virtual valve for 26 in this case to see at different level that we have a complete seal or not to avoid any problem. So I'm going to go with more technical thing, and we have amazing interventionists in the room with us. So, Dr. Amri, I know I'm putting you in the spot there, but do you usually routinely balloon in the bicuspid aortic valve, or is it like on case basis?
Thank you, Sondos, for the nice presentation and the team. I think pre-dilatation is a prerequisite for any TAVI, any bicuspid aortic valve. And the success in bicuspid aortic valve came from pre-dilatation, by the way. If you don't pre-dilate, you are destined to fail in many cases. So pre-dilatation is really very important in these patients.
Okay. Dr. Faisal Al-Goufi, I also would like to hear your takes. In terms of your balloon size choice, do you go for like the minimal diameter, you go something in the middle, knowing this is a case of 26, knowing the sizes? You're going to go with which balloon as a like first take?
So I think again, for the bicuspid with the risk of complication, including an annular rupture, has been higher than the tricuspid, I usually go by the minimal diameter. But I have to say, I do extra work in a bicuspid where I flip the C-arm to look at the balloon expansion in another view, specifically in REO, in order to make sure that I achieve full expansion. Otherwise, it's not uncommon that I actually upgrade my balloon size to ensure that I prepare the annulus well.
Okay. So we did what you said, and we did with the initial attempt to cross the valve, but the valve wasn't crossing. So I would like to ask Dr. Mugheri, I mean, he's the hero or the captain of crossing the uncrossable. So what is your next step, knowing what you know now?
Yeah, I think the good dilatation first, then using the good support wire, whether the Safari or pre-shaped wires, or going back up to the more stiffer wires like the Myers or Landerquist. So it's the wires, it's one of the possibilities. The other thing is to use the anchoring method. So to either to take as the wire as the second wire as a body wire, or to support it with a balloon. And the balloon support is inflate the balloon even if it is partially, and slide the valve while the balloon started to deflate before deflating completely to take the place, because the recoil mechanism is, it may be the mechanism to stop the valve. So it's the inflating the balloon, deflating the balloon slowly while deflating, advance the valve. This it may help.
So we upgrade the balloon to 25, and from the contralateral side with a 12 French, and we ballooned, and still the valve didn't go. So we use as you can see here, we use the balloon as a body system to help us to navigate and drop the valve and amend it. I would like to ask here also Dr. Hijji, will you consider at this stage calling a surgeon in the room, Dr. Muhammad Hijji? Or you will like, business as usual?
I mean, this is a nice technique of crossing the valve using a balloon-assisted technique. At this stage, you crossed. Looks like everything is fine. and you deploying the valve with good expansion. The only thing I'm not seeing the right coronary flow, to be honest, so I would be worried about that.
Okay. So we can see that we deployed it as a 26 Ultra. Things were very, very good. But my question is, seeing this, I would like to hear from the panelists. Dr. George, do you think we should go for a second inflation, or you will be happy and depend on the hemodynamics?
Well, based on what it was also explained before, that there was a lot of calcification to the right side, and this is exactly what happened there. You have predicted that this is the under-expansion of the valve in this way. I would believe that we should not push it more in this direction, and that we should accept this result.
Okay, so less is more. The enemy of good is better. So we close the case, and the patient have an eventual hospital course. Next morning, he went home, and he reminded everyone that his ejection fraction was 45. It became 55 the next day, and there was no gradient. I would like to ask Dr. Jamila, any specific images you take extra when it comes to post-TAVI assessment, when it comes to echo?
So thank you, Dr. Sondos. I think the standard views to assess the aortic valve procedure, in addition to the prosthesis location, is very important. We also had to add the Doppler assessment, so every view that help us in getting the proper alignment of the Doppler alignment to give you the maximum gradient that we can check. And then we have to focus on views that can assess paravalvular leak. So the short axis as well as the long axis views and the apical views will also help you for the paravalvular leak. So the migration of the prosthesis, the gradient, and the presence or absence of any leak.
Great. So I would like also to hear from Dr. Mogheri, because we always have the debate inside of the procedure room about the positioning of the valve. We always talk about, should we go higher? We have established having the good system, predilate, now the position. You always we have this argument in the room, should we go high, should we go low, should we put it in the annular side? What is your take, Dr. Mogheri?
Yes, once we started with the sizing of the valve, is a combination of everything. So the intercommissural distance, and then the circle method to take the tip of the leaflets, because the anchoring now is not the annulus. The anchoring is at the fusion and the raphe, the maximum calcium. So once you have if you go low, you may end up with the paravalvular leak, maybe significant, or under expansion of the upper part, which is the lowest radial force in the valve, because if you use the balloon expandable, the radial force is at the crowded or the horizontal honeycombing the down in the frame. So you take the ratio, not 80-20 now, is make it less. Maybe it's 90-10 or 95-5%. Even zero, it's acceptable in the bicuspid with the calcified raphe, so your anchoring is not the issue. Your issue is to seal everything and to take to make the oval shape circular as much as you can.
Great. I haven't asked this side, so you're going to be next, Dr. Abdallah. My question is, since your center is more of a self-expandable valve implanter, or you have more experience, or you have both, I'm sure. So my question is, any thoughts when it comes to self-expandable valves positioning, when it comes to bicuspid aortic valve? We talked about balloon, but when it comes to self-expandable, what are your thoughts?
Well, the data, basically, when we talk about bicuspid aortic valve, there is no basically preference over bicuspid or self-expandable valve versus balloon expandable valve. But usually we use the same techniques when we talk about self-expandable valve. However, we try to be using more pacing sometimes in these cases, and basically we ensure the wire position usually more toward the LV to ensure the patient, the valve is aligned to basically annular level. And the same as Dr. Mogheri said, when we deal usually with tube or flare shape, we have no issues. However, when you deal with tapered, basically annulus to orifice, basically alignments, then we have to be more basically going up, avoiding the LVOT.
Okay, great. Thank you, Doctor. So with that, we will be finishing the first segment of the morning session. but still we are here. And you're going to get bored with me because I'm going to talk again, but I'm going to make my companion, my imager, my brother, Dr. Zakaria, hold the screen with me in this case.